Hi everybody. Let's talk about in the immune system. First of all, as review, remember that it's important to understand what an antigen and an antibody is as we talk about patients that have autoimmune disorders. If you remember, antigens are, in short, described as foreign substances, whereas antibodies are actually produced in response to the antigen, and it's produced to actually destroy the antigen. So for patients that have autoimmune disorders, their immune system, first of all, is unable to recognize self. So it sees things that it itself, the body itself, has produced. It sees it as foreign, and therefore the immune defenses are directed against it, against that normal host tissue, to try to destroy it. We know that autoimmune disorders can actually affect any tissue of the body. You will talk about rheumatoid arthritis, which is another autoimmune disorder, when you cover the musculoskeletal disorders. Contributors to the development of autoimmune disorders include genetics. We know that certain autoimmune disorders are more prevalent in females, and that unfortunately they tend to overlap. So patients that have one autoimmune disorder may indeed have a second. Autoimmune disorders have been associated with abnormal stressors, and not just the onset of an autoimmune disorder, but the exacerbation of one as well. We know that patients that have autoimmune disorders often experience frequent, even progressive, relapsing, remissing disorders that are characterized again by exacerbation or remission. When we talk about impaired immune response in terms of our lecture, we're going to talk about those that are either congenital or acquired. We're going to talk about them in response to T cells and B cells. And it's important to remember that regardless of the immune disorder, that these patients are at an increased risk for infection because either the T cells or the B cells are impaired, and that reduces the body's ability to defend itself against, again, either foreign antigens or abnormal host tissue. Now, the first autoimmune disorder we're going to talk about is systemic lupus erythematosus, or SLE. Lupus is a multisystem inflammatory autoimmune disorder that is characterized by a diffuse overproduction of autoantibodies, meaning our body is just producing these antibodies that in turn attack organs and tissues that they shouldn't attack, that are not actually antigens. We know that lupus is one of those autoimmune disorders that's more frequent in women, approximately 10 times more frequent in women, and that it's about 3 times more frequent in the patient. So lupus is an overproduction of autoantibodies, again, either brought on by genetic factors, hormonal factors, environmental factors, and even certain medications. And sometimes it's difficult when patients are diagnosed with lupus to be able to determine what exactly it is that brought about the disorder. Regardless, we know that there are B and T cell involvement. B cells are instrumental in promoting the onset of the disease and then again in the exacerbation of disease. We know that lupus, again, because it's more often in women, is often also more often in women during childbearing years. We know that in terms of environmental factors, that sunlight as well as thermal burns, can lead to the development of lupus. And then just to name a few medications that could increase risk for this disorder includes apresiline, which we know is an antihypertensive, thorazine, INH, and some anti-seizure medications. Now, the onset for lupus can be either insidious or acute. We know that it affects all body systems. Remember, insidious means slowly. So it may develop either slowly or very acutely. And generally, when patients are admitted, their clinical manifestations include arthralgias or painful joints, synovitis, joint swelling, tenderness, certainly pain and movement, particularly in the morning. Patients will complain of morning stiffness or pain on movement, and that's not unusual. That's an expected finding for a patient with lupus. We know that an early symptom of lupus is the butterfly-shaped rash that you'll see across the bridge of the nose and the cheeks. And it's also thought that it's this rash that is the precursor to a more systemic involvement. Other skin manifestations include erythematous plaque or palmar erythema, where the palm of the hand itself is very red. Other clinical manifestations include with oral lesions, we see patients having buccal mucosa or hard palate lesions. These oral lesions often accompany skin lesions and are sometimes associated with exacerbations. Serum creatinine and levels, as well as the patient's urinalysis levels, need to be screened because of the risk for renal involvement, particularly in patients that already have hypertension, and then also because renal involvement can lead to hypertension. Neurological clinical manifestations can be very broad and often present very subtly in terms of changes in their behavior or in their cognition. Other general manifestations include fever, fatigue, weight loss. Patients will sometimes develop pleurisy. And one of the important cardiac clinical manifestations to remember is that these patients can develop pericarditis. So if you auscultate a patient's heart sounds and they are abnormal, particularly if they have a friction rub and pain in the left scapular area, then we are concerned that the patient has indeed developed pericarditis, and that would be an important reason to alert the medical team. This is just an illustration of some other clinical manifestations that you may see. The Raynaud's phenomenon, I believe you guys have studied that in MedSurg 1 as well, and that's where it's like in terms of vascular problems, when they go outside, the tips of their fingers are very cold and tingly. Lupus nephritis, which is again why we need to monitor the patient's BUN and creatinine. On physical assessment, for a patient with lupus, there is no single test that confirms the diagnosis. We know that labs that can be performed that will be certainly diagnostic in terms of initial screenings include looking for a CBC in terms of moderate or severe anemia, looking to see on the CBC if they have thrombocytopenia or if they're leukocytosis or if they have leukopenia. Two other laboratory findings that are also often used for screening for lupus are an ANA and a C-reactive protein, or a CRP, and an ESR, or an erythrocyte sedimentation rate. So ANAs, CRPs, and ESRs are also looked at along with the CBC when patients are initially screened. And then, of course, it's important to look at the patient and not just our lab studies to confirm a diagnosis. When we think about medically managing a patient, or about the healthcare providers medically managing a patient, the very first thing that has to be understood is that the patient in an acute episode, or are they experiencing chronic disease. The treatment for lupus is aimed at preventing the progressive loss of organ function, particularly acute disease like, again, the renal nephritis, and preventing complications, because the disease itself cannot be cured, but it can be managed. And so it's, again, managed at preventing loss of organ function. Pharmacologic therapy for lupus includes corticosteroids. Corticosteroids are used topically for cutaneous manifestations. Lower oral doses are also used for minor disease activity. But if a patient is experiencing a major disease activity or major exacerbation, then you would expect that they would receive intravenous corticosteroids. It's very important to teach patients that they cannot stop corticosteroids abruptly, and that even if their symptoms improve and they feel like they're better, that to continue that sense of wellness, and the patient has to also continue the corticosteroids and any other medications that are used to treat the disease itself. Again, not to stop those drugs abruptly. Antimalarial drugs are effective for cutaneous lesions, for other mild systemic features that patients may present with. And then the immunosuppressive agents are really reserved for the more serious forms of lupus. And certainly those are medications that we would be worried about having a pancytopenic effect, meaning that it would affect the red cells and the white cells as well, and the platelets as well. In terms of nursing management for lupus, be sure and look in your book on the chart that illustrates all of the nursing management goals as we think about care for these patients. But some of the things that are particularly important is that these patients need very careful, not just physical, but psychosocial assessment, again, because this is a chronic illness and will certainly have its effect on the family and significant others, as well as the patient. Activities that we teach the patient to avoid include exercise that is too high impact. We know that the patient doesn't need to have even low impact aerobics, because we know that this type of activity can really exacerbate not just the disease process, but also the feelings of fatigue. They should also avoid hot baths for those very same reasons. Also teach the patient to avoid sunlight and ultraviolet light. And then also nutritional teaching, particularly as the risk for cardiac involvement is a concern. So let's talk about HIV. HIV stands for Human Immunodeficiency Syndrome and is a specific type of virus called a retrovirus. And we know that there are at least 2 major strains that are found worldwide. One, HIV-1, found primarily in the United States and Europe, but there's also an HIV-2 strain that is more prevalent in West Africa. And we also have concerns in terms of HIV testing and, HIV treatment. Now, because patients don't always adhere to medication regimens, we also have to worry about patients developing resistant HIV, and that's also a topic for discussion perhaps later, but it's a very concerning phenomenon that we're now seeing not across the United States and even the world. We know with HIV, the CD4 count and the T cells are what really mark the immunosuppressive state of the patient, and we know that they are predictors of the patient's risk for contracting opportunistic infections. When a patient has HIV, these lab values are monitored to track the disease and are also used to determine the type, effectiveness, and any needed changes in any of the antiretroviral therapies that the patient may be engaged in. We know that HIV destroys the host's immune system by destroying the CD4 and the T cells. We know that there are genetic mutations, just like we talked about in terms of strains. We know that as of now there is no cure, and that eventually patients will develop full-blown AIDS. When we talk about acquired immunodeficiency, we have to remember that the type of the virus that HIV is one that replicates easily and mutates frequently, and therefore it's very difficult sometimes to manage this disease. It's also why it has been difficult for scientists to create a drug that consistently treats the disease, or even a vaccine. We know that the disease limits the body's ability to fight infection, and so a patient that has AIDS, full-blown AIDS, certainly has a significantly weaker immune system than even the patient that's initially diagnosed with HIV. Eventually, the immune system becomes overwhelmed by the virus and is nearly totally destroyed, and unfortunately, again, there's no cure for AIDS. HIV and AIDS was initially discovered in the early 80s. We knew even back then that it targeted and killed T cells. We knew that normal body systems are unaffected, that the immune response is not launched, and so therefore, because of the type of virus that it is, our body doesn't have the defenses to actually try to kill the antigen before it takes over. The process of HIV infection is a very complex one. The virus enters the cell with a CD4 receptor. Without a CD4 receptor, it cannot enter the cell. We know that reverse transcriptase then forms DNA from that viral RNA. It enters the cell nucleus along with DNA, and it inserts itself finally into the host DNA. And that's where the direct proteins and enzymes that replicate the HIV portion of the DNA is, and where more HIV is initially created. So this is just a very simple, if you will, illustration of how HIV infection occurs. But we know that it is a complicated procedure. If you remember back to microbiology, our CD4s and T cells comprise about 70 to 80% of our circulating cells. So that's a lot of cells. And we know that the virus, the HIV virus, actually destroys about 1 billion of these cells per day. And what happens is that eventually the bad cells destroy the good cells faster than the body can replace the good cells. We know that the enzymes transcriptase, integrase, and protease are responsible for reading the DNA for copying, inserting, and assembling those proteins into the infected cells. And the only reason that I even mention that now is that when we talk about medications, you'll see anti-transcriptase, anti-protease, anti-integrase. And that's what these drugs are actually aimed at doing, is preventing these enzymes from doing their job. Modes of HIV infection or AIDS transmission, certainly unprotected sex, and particularly patients with multiple sex partners, sexual intercourse with a partner of unknown HIV status, IV use or shared needles, drug or alcohol abuse. Those with a history of STDs are often at a greater risk because of lifestyle. And then the history of blood transfusions between 1978 and 1985. It's felt like from 1985 on that the process by which blood is monitored creates a safe supply in the United States. Remember that HIV cannot be transmitted by casual contact. It cannot be transmitted by food, air, water, insect bites. We know that it's not probable for it to be transmitted via coughing or sneezing, dry kissing, hugging. You cannot catch HIV from a swimming pool, and you cannot catch it through a toilet seat. How you can catch it is through blood or any other potentially infectious materials. And so body fluids like blood or semen, or vaginal or cervical secretions, amniotic fluid or breast milk are all bodily fluids that can indeed serve to transmit the HIV virus. When we talk about variables that occur that affect whether the patient actually acquires the infection or not, you have to think first, what is the patient's underlying immune status? So if it's a patient that already has TB or already has other medical conditions or comorbidities that create an altered immune response, then these are patients that certainly have a greater risk for developing HIV. And then certainly when we talk about the way it's transmitted, when we talk about the blood versus semen versus vaginal secretions, etc., it's important to understand that the blood itself is more likely to carry more virus. And so depending on how the virus is transmitted will also affect the risk of the patient developing HIV. So let's say that the patient develops HIV from either a needle stick or some other blood transmission, then they are more at risk for developing the virus than, per se, a patient that came in contact with bodily fluids other than blood. When we talk about IV drug use, we know that sharing needles, particularly without sterilization, increases the patient's risk for developing HIV. And certainly as a nurse, or in terms of people who are at greater risk because of occupational exposure, we know that having a needle stick rather than, say, have a patient spit in our eye or something that doesn't involve blood, we know that that needle stick will create a greater risk for our developing HIV than for other modes of transmission. We know that HIV can be transmitted through sex, and it's not just intercourse, but through other modes of sexual activity. Intercourse, oral, anal, as well as digital. You've probably talked about mother-to-baby transmission in your OB course. We know that there are certain processes that have to go, the mother and the baby have to go through to decrease their risk of developing HIV. We know that about 25 to 35% of infants born to HIV positive moms actually develop the virus, and that it's important to test test the newborn at around 48 hours of age. Now, when we talk about post-exposure prophylaxis, this is really important for those of us who have a heightened occupational risk. We know that PEP is recommended when occupational exposure occurs, that the status of the source patient has to be determined in order to guide the need for HIV post-exposure prophylaxis. That's if possible. And that's why patients, when they sign consents for hospitalization, there's often something in there in the small print sometimes that says they agree to be tested for HIV should there be an occupational exposure. We know that PEP medication regimens should be started as soon as possible after exposure to HIV, and they should be continued for at least a 4-week duration. It's really, really important to understand this, in that the research confirms and tells us that for those who are exposed to HIV, the quicker you start post-exposure medication regimens, the less likely you are to develop HIV. And the recommendation is that medication starts within 1 to 2 hours, no later than 2 hours of your exposure. The newer recommendations for PEP meds include 3 medications, and again, these antiviral medications are all aimed at treating each of the different enzymes that are involved in the production of the HIV virus. Close follow-up for exposed personnel is provided and should be provided by your facility. Baseline and follow-up testing is generally performed at 6 weeks, 12 weeks, and then again at 6 months. And then once you've had an exposure, follow up again within 72 hours. And generally, if a patient is still seronegative at 6 months, he or she will not develop HIV. That really have sometimes a general feeling of wellness, and again may not know that they have the disease, and the high level of viral replication is actually happening inside their bodies, and so therefore they are really at risk for developing or for transmitting HIV. And let me read you something that's actually from one of the latest articles on HIV. It says that extremely high levels of infectious virus becomes detectable in serum or genital secretions during acute HIV-1 infection and can persist for 10 to 12 weeks. The CDC says that the rate of transmission, particularly sexual transmission, is 26 times higher than during this period than with an established infection. So again, if you have a patient that doesn't suspect that they have HIV at all, then they may go many weeks, months, even, where they don't get tested. And so we know that during those initial weeks, particularly the first 10 to 12 weeks, that the patient is significantly more likely to transmit the virus. Okay, let's talk about stage 2, which is generally thought to be the asymptomatic stage. In this stage, the CD4 count is greater than 500, And that's really important to remember, because remember we said that we look at T cells and CD4 counts. The body generally has sufficient amounts of immune response to defend itself against pathogens, so it's not likely that these patients will develop opportunistic infections. Sometimes this stage can last for an average of 10 years and even more. We can think of people even like Magic Johnson who've been pretty asymptomatic for longer than 10 years. Patients can have some benign symptoms like swollen glands, and it's a very good thing that during this stage the level of HIV in the blood drops to very low levels, and so the risk for transmission is decreased, though we know that the patient needs to exercise responsible precautions. Another thing to remember about stage 2 is that it is at this point, the viral set point, that is predictive of the rate of the disease progression. So the quicker that the patient's viral load returns to near normal, the better it is in terms of prognosis for how long this stage 2 will actually continue. And as long as the patient has adequate CD4 cells or T cells, they are able to, for the most part, preserve immune defense and remain healthy. Stage 3 is the symptomatic stage when symptoms actually develop. We know their CD4 count stays above 200 but drops below 500. We know the immune system begins to deteriorate because of this very thing, and this is when we may begin to see the emergence of certain opportunistic infections and cancers. We will see a gradual decline of CD4 cells and T cells, and again, like I said, they'll develop symptoms that are representative of the decrease in their immune function. This is an illustration of what some of the symptoms may occur for patients in this stage of HIV. Certainly fever, weight loss, malaise. It's really important as we manage our patients, take care of our patients, is to teach them to take their temperature every day, to know early whether they're developing a fever, again, so that if they do develop an infection of any kind, even a sinus infection or something that seems fairly benign, that it can be treated quickly and the patient can avoid complications from it. And then stage 4 occurs when the CD4 count drops below 200. And this is really important to remember as the immune system weakens the most. The illness that the patient has experienced previous to this stage is no more. They develop symptoms that are certainly more bothersome than they've ever experienced. And we know that their illnesses can become very severe and can lead to the progression of AIDS. When a patient is develops AIDS, they have to have developed at least one opportunistic infection in order to get that diagnosis. So as the viral load increases, remember viral load is an indicator of how much of the virus is in the patient's blood. As that number increases, we know that the number of CD4 T cells drop because, again, our body is not able to produce the good cells or the healthy cells as fast as our body is making the bad cells or the HIV or replicating the HIV. Gerontologic considerations, we know that there's 1/4 of the people living with HIV are older than 50 years of age, and that's usually not expected. And the reason that seems to be according to science is they feel like it's safer to have unprotected intercourse. They don't consider themselves to be at risk and may even have social bias toward homosexuality, but may at the same time be somewhat sexually promiscuous, and therefore their risk develops because of that itself. We know that even patients older than 50 are IV drug users or may have received blood that was infected with HIV before 1985, or they may come in contact with the virus, and because they have a reduction in their immune system, they aren't able to fight that virus. Testing for HIV. We know with testing, it's always anonymous. We know that we never use the patient's name, but rather give them an identifying number. We can only issue the test results in person to the recipient. We cannot issue test results over the phone, and we have to make that clear to the patient because they may expect that. The person's name is recorded along with the HIV results, and when that is done, and it has to be done in terms of the legal chart, and then also reporting to the state and to the CDC, we have to report the patient's name, but of course we understand that that's confidential information. Specimens to screen a patient for HIV can be done using either blood, urine, or oral secretions. We know that even more so, you can go to your local drugstore and find testing kits that will allow us to do home screenings of HIV. Blood detection tests are by far the most readily used, particularly in acute care. There's something called the ELISA or the EIA, which is an enzyme immunoassay test. The ELISA used to always be used. We now know that EIAs are used more often, but either of those is in terms of this lecture, we will confirm that it's this type of test, one of these two types of tests, that are initially used to screen a patient who is thought to have HIV. Now, even last semester, one of the things that I taught was that if the patient had a positive ELISA or EIA, that test itself was repeated. The latest literature now states that some organizations, some hospitals, some health departments are no longer using the second ELISA or EIA as a confirmatory test. And so for the purpose of this lecture and for testing, I want you to know that the ELISA or EIA is the first test that's used to screen patients for HIV. If that test is negative, then the patient is considered HIV negative and can follow up in 6 months. If that EIA or ELISA is positive, then a Western blot confirmatory test is performed. And if the Western blot confirmatory test is positive, then the patient is considered to have HIV. I don't want to get into a lot of information about why there's some controversy about what blood detection tests are used, but just to explain it very simply, we know that the ELISAs or the EIAs are used, even though they're used very widely, they detect antibodies, antibodies, not virus. And so during that period where there are no antibodies, some sources say up to 3 weeks, some sources say even up to 12 weeks, that it would be that long that the patient would be transmitting the virus unknowingly. And so there are other tests that they're looking at that are more sensitive to the virus itself, and I'm sure in your studies as you graduate later you will learn more about that. But again, for testing purposes, you know that the very first test that's done is the ELISA or the EIA, and that's done to detect antibodies. If that test is positive, then a Western blot confirmatory test is performed to confirm that initial test. So on this screen, I want you to mark through if the EIA is positive, the test is repeated. I want you to mark through that right now. If the EIA is positive, the test is repeated. That is not how I will test you because of these changes, and I meant to change that on the PowerPoint, and I apologize. If the EIA or the ELISA is positive, then the next test that's done is a Western blot. If the EIA, only one, and the Western blot, only one, are both positive, then the patient is considered to have HIV. CD4 T cell counts are very important to monitor for patients that are able to still progress and do well, because they're actually looking at do they have more T cells and CD4 cells than they do virus, and so it's these labs that are looked at to determine the progression of disease and to guide therapy. And as the disease progresses, the CD4 count also decreases. So again, the viral load increases and the CD4 decreases. The more virus there is, the less normal cells there are. So the viral load will increase and the CD4 will decrease. A normal CD4 count is between 800 and 1200 cells. And again, that's what we would expect for the patient who has a relatively normal immune system. Viral load measures the amount of the actively replicating HIV and correlates strongly with the disease. So the lower the viral load, the less active the disease. And some patients will even have their viral loads tested and it'll say undetectable, and that's wonderful. And that would also imply that their CD4 counts are very good. But again, as the viral load increases, the CD4 count will decrease. Urine testing, there's something called a blot. There's something called an OraSure that is used. It's a buccal pouch testing, not saliva. And it is thought that it is as sensitive as blood testing, and it's a safe way to screen for HIV. But we know that false positives are sometimes seen in people that are at high risk for HIV. So that's why it's really important in patients that have a positive test also have some type of confirmatory test. And you can just look at this on your own. Pre-test counseling is really important, particularly explaining to the patient how the disease is transmitted, how it's prevented, and what the risk factors are, which we've covered initially. And then post-test counseling. Let me also say before I get to post-test counseling that, again, the reportability of positive results cannot be done over the phone, that it has to be done in person, and that it's really, really important to explain that to patients so that they don't become disillusioned about when you tell them that you can't give. So post-test counseling is an opportunity for us to clarify the test results along with the healthcare provider. We'll help them understand the need for additional testing and then help them understand ways that they can promote their own safe behavior. We know that HIV is a reportable disease, and so we have to report it to not just the state but as well to the CDC, and so we have to explain that to patients as well. Patients often want to know when they're going to start HIV therapy. They want to start right away, understandably. It's important to let them know that there is not a cure, but that the goal is to prevent or delay the development of opportunistic disease. And the recommendations generally are that drugs should be started before the CD4 cells fall below 200. And that's why CD4 counts are so important when healthcare providers are determining when to initiate medication. Some providers will start medication much sooner. Unfortunately, there are variables that involve insurance and money. These drugs do not inhibit the reproduction. They do not kill the virus, but they do inhibit the reproduction of it. They do not kill the virus, but they do inhibit the reproduction. We know they are very expensive. And that's why, even though some providers may think, even at a CD4 count of 350, that a patient needs to start antiretroviral therapy, sometimes patients are not able to do that because they simply cannot afford the medication. And then another thing I want to mention again, is drug resistance. And drug resistance occurs either by receiving the virus that is drug resistant, or when the selective drug resistance in the patient actually develops, and that is because the patient doesn't take their medication like they're supposed to on the regimen that has been prescribed for them. And so that's why teaching them and trying to identify barriers to being able to stay consistent with their medical regimen is very important, understanding what those barriers could very well be. Options, antiretroviral medications that are used include nucleoside reverse transcriptase inhibitors, and probably the most common one is AZT. The next one is non-nucleoside transcriptase inhibitors, and one of the more common ones is Viramune, and then protease inhibitors and Norvir. Opportunistic infections that occur with HIV and AIDS, again as the CD4 count drops, is tuberculosis, strep pneumonia, certainly Kaposi sarcoma, herpes, and even influenza. Respiratory clinical manifestations of patients with HIV and AIDS include certainly pneumocystis carinii pneumonia, which is seen as the most common life-threatening infection for patients with AIDS or HIV. We know that the initial symptoms are often nonspecific and can include a non-productive cough, fever, chills, dyspnea, and chest pain, and that if it's left untreated can progress to pulmonary impairment and even respiratory failure. Treatment for patients with pneumocystis carinii pneumonia or PCP pneumonia include pentamidine or TMP, SMV, and even can sometimes receive these medications prophylactically if they start developing symptoms but do not have an x-ray that confirms the diagnosis. Other respiratory clinical manifestations that would serve as an opportunistic infection include Mycobacterium avium complex or MAC infections, and then tuberculosis. And so if you have a patient that has a CD4 count that you know could represent the development of opportunistic infections, if they develop hemoptysis, then you would immediately place that patient on respiratory isolation, and then after doing so, you would call the healthcare provider. This slide shows a lung that's a healthy lung, and then a lung that is infected with Pneumocystis carinii. GI complications include oral candidiasis that can progress from the oral cavity to the esophagus and the stomach, and these are treated with anti-yeast antifungals like Miselex troches, nystatin, or even ketoconazole. Patients can sometimes develop diarrhea that's related to some type of HIV infection or enteric pathogen. There's a medication called octreotide acetate that patients can take for severe chronic diarrhea. This is not something that we would give a patient with a common bout of diarrhea. It's for patients that have very severe chronic diarrhea. And then, of course, wasting syndrome, which represents a 10% weight loss along with chronic diarrhea or chronic weakness and fever without any other causes. These patients have a protein energy malnutrition, so they don't have enough protein. They're not able to absorb and use protein. They have anorexia, again, diarrhea. They're, again, like I said, unable to absorb protein and other nutrients that would help them be healthy. They also may have a very difficult time eating because of nausea and vomiting, and that certainly can lead to wasting syndrome. There is a medication called Megace, M-E-G-A-C-E, and you may have seen that prescribed to other patients in the hospital, but we know that it is an important drug for patients that have GI complications with HIV and AIDS, because it promotes weight gain by actually increasing the fat stores in their body. And so it's not unusual to see patients with these GI manifestations be taking that medication. Opportunistic infections also include parasitic infections. Again, that's the Pneumocystis carinii. Candida, Cryptococcus are also infections that can be seen. So that's why we have to really ask questions like, do you have a cat that you clean up kitty litter? Do you have a bird that's caged that you clean up excrement? And because all of these kinds of scenarios can cause the patient to develop these opportunistic infections. With Pneumocystis carinii, as we said in the previous slides, often they don't have symptoms, but if they do, it's often a non-productive cough, fever, chills, shortness of breath, chest pain, and they may even be minimally hypoxemic. Candida is actually relatively common in most HIV patients, and we've probably all seen Candida. It's just they look kind of creamy white patches in the oral cavity. They can be very painful, particularly as they disseminate to other body places in the body. And it's not unusual for a patient to have to take narcotics when they develop fungal infections that disseminate. Oncologic clinical manifestations, Kaposi sarcoma, cutaneous lesions that may involve multiple organ systems. We know the lesions themselves are uncomfortable. They can cause disfigurement, ulceration, and a potential for infection. Kaposi sarcoma is the most common HIV-related malignancy. We know that it involves the endothelial layer of the blood and the lymphatic vessels. Again, it can either be localized or disseminated, and we know that the spots or the lesions look brownish pink to deep purple. So in a patient that has Kaposi sarcoma, we would not be alarmed that they had brownish pink or deep purple lesions. We would expect that they would indeed have those types of lesions. And then B-cell lymphomas are also a type of oncologic complication that you can see in patients with HIV and AIDS. And this is a picture that illustrates what those Kaposi sarcoma lesions look like. Neurological manifestations, peripheral neuropathy, HIV neuropathy. You know, if we have a patient that we're taking care of that has HIV and AIDS, and we see that they have this progressive decline in their cognition and their behavioral or motor function, then we suspect that it is directly related to the infection, the HIV infection, and represents an HIV encephalopathy. Cryptococcus neoformans is also a type of infection that invades the brain related to HIV. And then certainly patients develop mood disorders like anxiety or depression. And that again is relatively common and also very important to address. This slide illustrates these and other opportunistic infections that we have spoken about. Nutritional care of patients with HIV, again, very important. Skin integrity, respiratory status, fluid and electrolytes knowledge level. If we are doing an admission assessment on a patient with HIV and AIDS, the things that it's very important, some of the things that is very important to ask is, what is the patient's current medication regimen? That's important to know. It's also important to identify support systems. Who do they have in their lives to help them? Depending on, again, at what level they are in their disease, they may need some help with facilitating someone to come into their home, etc. It's also important to ask them what their immune system function is, and they will know that. If we asked just the average patient, what's your immune system function, they probably wouldn't really be able to tell you that. But for a patient that has had HIV, they're very well aware of the need to monitor their CD4 and their viral load count, so they will know about what their last levels were. So it's important to ask them that. And then, because this is a reportable illness, we have to ask the question, if the patient is engaging in sexual activities and who their partners are. And sometimes the infectious disease director will do that or whatever. But again, this is because it's a reportable illness, and the state actually notifies patients who anonymously who we think have been potentially exposed to HIV via sex. So how do we treat opportunistic infections? Well, it varies according to which opportunistic infection we are treating. The chart that we talked about when we first initially spoke about opportunistic infections is a good one to look at. Megace was one of the drugs that we looked at closely in terms of wasting syndromes, etc. What are ways to actually avoid HIV infection? Well, abstinence, monogamous relationship, protective, and sterile needles. Abstinence is the only 100% effective method of not acquiring HIV or AIDS. And then also refraining from other sexual contact beyond just sexual intercourse. And then also refraining from the use of IV drugs. Complications vary from patient to patient. We've talked about wasting syndrome. We know that wasting syndrome is relatively common in patients with full-blown AIDS, particularly as their CD4 counts drop. And we've already explained that represents a 10% loss of body weight, chronic weakness, fever, diarrhea. And that should be 2 loose stools. AIDS dementia complex is when there is an infection. The infection itself invades the brain and central nervous system. It may begin as mild and can progress to severe. Patients will have memory impairment, personality changes, hallucinations, changes in balance, slower response. And at the end stage of AIDS, it's again very common, just like with wasting syndrome, for patients to have this AIDS dementia complex. And this concludes our lecture on HIV and lupus. For the immune disorders. Let me say that for testing, all of the questions will either come from lupus or from HIV or AIDS. So just so that you're clear about what to study for the exam. And if you have questions, please feel free to email me and I'll be glad to help you. Thank you.